So Tom, whenever you're ready.
Okay. So our next presentation is on bronchoprovocation testing and exhaled nitric oxide. Our presenter is Dr. Mansur Assaad, and he is our a second-year pulmonary and critical care fellow at Guthrie. And like I mentioned with Raj earlier, Mansur had the opportunity to come on campus pre-COVID and get to check everything around just in time to have the dubious honor of arriving during COVID. So it's always a pleasure to work with Mansur, and please go ahead and with your presentation. Thank you for being here.
Thanks, Tom. Appreciate it. I don't use Zoom often, so bear with me. Let me see if I can share my screen.
Should be a little green button down at the bottom.
Oh, I think I got it. Okay, can you see the slides?
Yes.
Okay.
Perfect.
Excellent. I just want to thank you all for having me today. I really appreciate you giving me this opportunity to discuss a very relevant topic to all of our fields of practice. I apologize I wasn't at Raj's presentation. I was rounding in the ICU, so I apologize for missing that portion of it. But this is just going to be essentially a quick add-on to what Raj discussed. We're going to talk about bronchoprovocation testing, and then the use of exhaled nitric oxide to assist with the diagnosis of asthma. All right, so three main objectives. First, we're going to talk about what the bronchoprovocation testing is, what that entails, the basic precautions and principles, and of course, the indications and contraindications as well. We're also going to talk about, which agent would you choose for the bronchoprovocation testing? Why not? We're going to talk about how to interpret the data and approach the difficult interpretations, and how to, log all that information so that the physician can interpret it in the context of the clinical setting. And then after that, we're going to kind of switch gears and talk about something that I don't think we do often here. It's exhaled nitric oxide. We're going to talk about how it's used clinically in diagnosing and characterizing asthma. So first and foremost, I'm going to talk about asthma. There's lots of different definitions out there. I like this one from the NAE PPR3 in 2007. They just recently updated their guidelines regarding management of asthma, but they provide a pretty encompassing definition for asthma. And I've kind of bolded the main characteristics. It is a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role. In particular, these include mast cells, eosinophils, neutrophils, lymphocytes, macrophages, and epithelial cells. In susceptible individuals, this inflammation causes recurrent episodes of coughing, sometimes at night, sometimes early in the morning, wheezing, breathlessness, chest tightness. These episodes are usually associated with widespread but variable airflow obstruction that is often reversible, either spontaneously or with treatment. It's kind of a mouthful, but I think they do a good job of it, highlighting the key characteristics of this clinical diagnosis. Just some epidemiology. It does affect 25 million Americans, and it accounts for over 12 million medical visits annually. 1/3 of those afflicted with asthma are actually children under the age of 18. We obviously see more adults here at Robert Packer. The clinical course of asthma is influenced greatly by exposures to respiratory viruses. I can think of one in particular these days, indoor allergens, tobacco smoke, and then other physical and social aspects of the environment. The most common cause of hospitalization for children in America is actually asthma. So there are historical features that increase the probability of asthma. The episodic nature of these symptoms. Sometimes they tend to worsen at night. Sometimes they're exacerbated with changes in the weather. And sometimes after exposure to a specific trigger or allergen. And sometimes they may just resolve spontaneously, usually after removal of a triggering stimulus. That's one of the key characteristics that can, in the right clinical setting, can help support the diagnosis of asthma. The presence of characteristic triggers, sometimes it's cold air, sometimes it's exercise, like I said, environmental allergens, chemical irritants, certain viral and bacterial infections, and then even certain medicines can predispose patients to asthma, particularly NSAIDs and aspirin. Symptoms usually occur within 30 minutes after exposure, and they resolve either with treatment or cessation of exposure. If they have a personal history of environmental allergies, including the presence of rhinorrhea, watery eyes, itchy eyes, with changes in seasons or exposure to allergens. If they have a family history of allergies or asthma, and if they have history of asthmatic symptoms as a child. These are all things that can predispose patients to developing asthma later on. So how do we diagnose asthma? Well, there is no gold standard test for diagnosing asthma. It is a clinical diagnosis, and you have to take into account several different things, including history, the patient characteristics, physical exam findings, and then the results of certain evaluations that can help assist in the diagnosis. That's predominantly what I'm going to talk about today. Things that can help you in diagnosing asthma: PFTs, bronchoprovocation testing, exhaled nitric oxide. Peak expiratory flow, we don't really use much for diagnosing asthma. We tend to use it more for monitoring patients, and we can use it to see or assess how they respond to treatment. And then we use other tests. We can use lab testing, we can do allergy testing, and then imaging sometimes can play a role. So what are you looking at on PFTs when you're evaluating a patient for asthma? Well, first and foremost, you should look at spirometry, and baseline spirometry should be obtained in all patients who are suspected to having asthma. If the FEV1 FVC is less than 70% or the lower limit of normal, that can help you determine whether the patient has baseline obstructive ventilatory dysfunction. If you assess the FEV1 itself, you can determine the severity of airflow limitation. You can also create a differential for the etiology of airflow obstruction based on the shape of the flow volume curve. I have a picture here of the standard flow volume curve. As you can see, the expiratory limb is kind of concaved inward, which is pretty indicative of expiratory airflow limitation. It's not specific. You can see it in COPD, you can see it in asthma, you can see it in bronchiectasis. Just note that sometimes spirometry can be normal in patients with asthma. We also look at a bronchodilator response when looking at spirometry. We assess this by administering 2 to 4 puffs of a short-acting broncho beta agonist or bronchodilator, then repeating the spirometry after 10 to 15 minutes. A positive bronchodilator response is considered an increase in FEV1 or FVC by 12% and 200 milliliters. You have to have both. The presence of bronchodilator responsiveness in isolation is not sufficient for making the diagnosis of asthma. You can see a positive bronchodilator response in other things like COPD, bronchiectasis, small airway disease, even cystic fibrosis. Sometimes you may have a false negative bronchodilator response, and you need to be aware of the potential causes of that. Sometimes an inadequate dose of the albuterol may be given. Sometimes use of the bronchodilator before starting the test can result in a false negative because it results in a maximum bronchodilator response at baseline. The presence of minimal airflow obstruction at the time of the testing. And then sometimes there may be the additional presence of irreversible airway obstruction due to airway remodeling, fibrosis, things like that. So bronchoprovocation testing. We use it in patients with a strong clinical suspicion for asthma, but have normal spirometry. We also use it in patients with unexplained respiratory symptoms, particularly cough or nocturnal awakening. It may be required sometimes as an asthma screening test for occupational reasons. Tests should always be interpreted in the context of the clinical history. This is very important. When we look at bronchoprovocation testing, we also take into account something called the pre-test probability of asthma. And the optimal diagnostic value for a methacholine challenge or any bronchoprovocation testing occurs when this pre-test probability for asthma is at least 30 to 70%. We're going to touch base on that in later slides. Methacholine challenge testing is more useful in excluding a diagnosis of asthma rather than establishing one, because its negative predictive value is actually greater than its positive predictive value. Contraindications to bronchoprovocation testing. Any condition that may compromise the quality of the test or may subject the patient to increased risk of discomfort. These are usually identified in a pre-test interview or questionnaire that the respiratory therapist will discuss with the patient. If any contraindications are identified, they should be discussed with the physician who ordered the test or the medical director of the lab before proceeding with the test. This table here is from the American Thoracic Society. It's a great resource, and they list several absolute contraindications. including the presence of severe airflow limitation depending on the FEV1, if they've had a heart attack or a stroke in the last 3 months, if their blood pressure is uncontrolled, or if they have a known aortic aneurysm. Those are all absolute contraindications. Relative contraindications do exist, and you do have to take them into account, including things like the degree of FEV1, the inability to perform an adequate spirometry, the pregnancy, nursing mothers, and if they're using certain medications that can potentially interfere with the medication administered during the test. So safety. Safety is very important with this test. Usually we use methacholine. This drug can cause bronchoconstriction. That's what it's supposed to do. That's the whole point of the test. So the safety of both patients and the technician should be considered in the design of the test room and the testing procedures. The medical director of the lab, another physician, or anyone who's appropriately trained to treat acute bronchospasm, including appropriate use of resuscitation equipment, must be close enough to respond quickly to an emergency. Patients should not be left unattended during the procedure once the administration of methacholine has begun. Medications to treat severe bronchospasm must be present in the testing area. This is a no-brainer. You must have things like albuterol, ipratropium, epinephrine, atropine for subcutaneous injection, and then additional items should be ready available. Oxygen, a stethoscope, things like that. This is all pretty standard with the setup of any PFT laboratory. Patient preparation. So patients should be given a list of items and medications to avoid before the test. This is just a generic list of medications that should be discussed with the patient to see if they're taking. It's from the European Respiratory Society. Things like, short-acting bronchodilators, long-acting bronchodilators, they should be stopped within a certain time frame and the minimum time interval from the last dose of the study is provided for each medication. This is just a sample sheet looking at the pre-test questionnaire. This is not the one we use specifically, but it gives you an idea of what we're asking. You can see the section on that lists what patients' drugs are taking and the date and time that they last used this. If they're having some symptoms, if they smoke, and if they do, when was the last time they smoked? Have they had any infections recently? And then you can start to see some of the contraindications that are absolute, like have you had a heart attack or a stroke in the last 3 months? If their blood pressure is inappropriately high, greater than 200, systolic, that is an absolute contraindication. Have they had an aortic aneurysm? Things like that. This is just a sample questionnaire. How do we prepare the patient? Well, first we want to explain the test to the patient, tell them that they may experience some discomforting symptoms. Sometimes they can get cough, chest tightness, but most patients tend to have no symptoms. They should also be warned that occasional severe symptoms may occur. Always ask the patient if they want to use the restroom before the test, because sometimes, particularly elderly women, they can develop stress incontinence. Evaluate for any contraindications and review the medication use. Patients must be able to understand the procedure and perform reliable spirometric maneuvers. And you can also perform a brief physical exam prior to the test. All right, which agents are available out there? The most common one, and the one we use, is methacholine. It's a synthetic derivative of the neurotransmitter acetylcholine. It comes as a crystalline powder. It is the agent of choice for nonspecific bronchoprovocation challenge testing. It comes in FDA-approved, prepackaged, sealed 100 milligram vials. It also comes as a bulk powder, and it should be stored with a desiccator in a freezer. The sealed prepackaged vials do not require desiccation or freezing. We normally dilute it to create varying concentrations and doses, and we can use sterile normal saline for this purpose. Histamine is also something that has been used. It does produce direct bronchoconstriction by stimulating the airway smooth muscle receptors at nearly equivalent concentrations when compared to methacholine. It is, however, associated with more systemic side effects, so you have to take that into account. Patients can develop headache, flushing, hoarseness, things like that. And then the bronchohyperactivity measurements may actually be less reproducible, they found, compared to methacholine. That tends to be why we don't use it often anymore. Another agent that we don't use here is mannitol. It causes bronchoconstriction, but in a more indirect manner. It increases the osmolarity of the airway surface, and that causes a release of mast cell mediators to result in bronchoconstriction. It's prepared as a dry powder in capsules containing graduated doses, and these are administered via dry powder inhaler. Due to the use of pre-measured doses, mannitol inhalation challenge may prove to be more convenient actually than challenges with methacholine. And in fact, they looked at a study evaluating 592 subjects, and it found that mannitol challenge appears to be safe when used to test for bronchoprovocation, and they actually didn't note any serious side effects. However, cough is a common side effect. There tends to be conflicting data with this, but overall mannitol may be more specific, but less sensitive compared to methacholine. Dosing protocols. So there's a lot of different protocols out there, each with their own variations and each with their own advantages and disadvantages. The two commonly used protocols, though, are the 5-breath dosimeter method and the 2-minute tidal breathing method. These two techniques are the most widely used in North America and Europe. And here at Robert Packer, we actually do a slight variation in the 2-minute tidal breathing method. So what is the 5-breath dosimeter protocol? Well, essentially the RT will prepare 5 concentrations of methacholine in sterile vials and then store in a refrigerator. You can see the 5 different concentrations listed here, and I'll talk about why these specific concentrations are important in later slides. You remove the vials from the fridge 30 minutes before testing so that the contents warm to room temperature. You take 2 milliliters of the first concentration into the nebulizer using a sterile syringe. The patient should be seated throughout the test, and then you perform baseline spirometry. Here's just an example photo of what some of the dosimeters tend to look like. As you can see, there's a mouthpiece, there's an exhalation filter, and then there's a reservoir for the medication to be used. This isn't how they all look, but this is just an example. So ask the patient to hold the nebulizer upright with the mouthpiece in his or her mouth. Watch the patient during breathing maneuvers to ensure that the inhalation and breath hold are correct and that the nebulizer is not tipped in one direction. Patient should be wearing a nose clip while inhaling from the nebulizer. At the end of a normal exhalation during tidal breathing, i.e. the functional residual capacity, instruct the patient to inhale slowly and deeply from the nebulizer. Trigger the dosimeter soon after inhalation begins. Some dosimeters will do this automatically. You then encourage the patient to continue inhaling slowly, about 5 seconds to complete the inhalation, and to hold the breath at total lung capacity for another 5 seconds. Repeat these steps for a total of 5 inspiratory capacity inhalations. Overall, it shouldn't take more than a couple minutes. After this, you measure the FEV1 about 30 to 90 seconds after the 5th inhalation from the nebulizer. Perform 3 or 4 maneuvers after each dose. At each dose, report the highest FEV1 from acceptable maneuvers. And if the FEV1 falls less than 20%, empty out the nebulizer, shake it dry, trigger the dosimeter once to dry the nebulizer nozzle, and then add 2 milliliters of the next higher concentration and repeat the previous steps. However, if the FEV1 falls more than 20% from baseline, or the highest concentration has been given, 16 milligrams per milliliter, give no further methacholine. Make note of any signs or symptoms the patient is experiencing. Administer albuterol, wait 10 minutes, and then repeat the spirometry. In patients who are concerned for vocal cord dysfunction and the patient's symptoms allow it, you can do full inspiratory and expiratory flow volume loops before giving the bronchodilator. This is usually noted before the test is performed, and the physicians should note if they're concerned about this in the pre-test ordering. So the next protocol is the 2-minute tidal breathing, a slight variation. Instead of preparing 5 concentrations, you prepare 10 concentrations of methacholine. If you note last time with the 5-breath dosimeter protocol, each concentration is essentially quadrupled from 0.0625 to 0.25 to 1 to 4 to 16. But with the 2-minute tidal breathing, they recommend doubling dose of each concentration. Again, up until 16 milligrams per milliliter. A lot of the steps are initially the same. Remove it from the fridge, let it warm to room temperature. You take 3 milliliters of the first concentration into the nebulizer using a sterile syringe. Again, patient must be seated throughout the test, and you perform a baseline spirometry. This is a sample setup of how the nebulizer is set up. As you can see, very similar setup, mouthpiece, exhalation filter. and then an area for your nebulizer solution. A lot of technical details here. You use dry compressed air to power the nebulizer and set the pressure regulator to 50. The flow meter accuracy should be checked with a rotometer. And then you adjust the flow meter to deliver the output established during the calibration procedure. Different labs will have different procedures and protocols. Again, make sure the patient has a nose clip. Have the patient hold the nebulizer upright with the mouthpiece in his or her mouth, and then you instruct the patient to relax and do quiet breathing, tidal breathing. Start the timer and then begin the nebulization. Assess the patient and make sure that they're breathing comfortably and quietly and not tipping the nebulizer in one direction. After 2 minutes, turn off the flow meter and take the nebulizer from the patient. Measure the FEV1 about 30 to 90 seconds after the nebulization is complete, and perform no more than 3 or 4 maneuvers after each dose. At each dose, report the highest FEV1 from the acceptable maneuvers. Similar to the prior protocol, if the FEV1 falls less than 20%, empty the nebulizer, add 3 milliliters of the next higher concentration, and repeat the previous steps. However, if your FEV1 falls more than 20% from baseline, or the highest concentration has been given, again, 16 milligrams per milliliter, give no further methylcholine, assess the patient for any signs and symptoms, give albuterol, wait 10 minutes, and then repeat the spirometry. Again, same thing. If you suspect vocal cord dysfunction, and the physician should note that before the test, you can do full inspiratory and expiratory flow volume loops. This is from the European Respiratory Society. It's a sample dilution schedule for both the nebulizer protocol and the 5-dose dosimeter protocol. As you can see, the methylcholine will come initially as a 100 milligram vial. They add certain amounts of normal saline, in this case 6.25 milliliters, to create the first highest concentration, which is 16 milligrams per milliliter. What they do is they add 3 milliliters of normal saline to this to make the next concentration, another 3 milliliters to make the next concentration, so on and so forth. That's the dilutional method that they suggest. Same type of thing for the 5 concentration dosimeter protocol, except you're giving more normal saline essentially because the concentration is going down by a factor of 4 each time. So how do we present the data? So the results are reported as a % decrease in FEV1 from baseline or post-diluent if a diluent step is used. The values of interest that we look at are the PD20 or PC20. The PD20 is the provocative dose that causes a 20% fall in the FEV1. The PC20 is the provocative concentration that causes a 20% fall in FEV1. Unless stated otherwise, it may be assumed that the PD20 or PC20 is calculated from the change in FEV1. If the FEV1 doesn't fall by at least 20% after the highest dose is given, which would be 400 micrograms, then the PD20 should be reported as greater than 400 micrograms. Don't extrapolate. For the PC20, similar thing. If it doesn't fall by at least 20%, report it as greater than 16 milligrams per milliliter. So in 2017, the European Respiratory Society actually published new guidelines recommending the following. You can base methylcholine challenge test results upon the delivered dose, causing a decrease in FEV1 by 20%, meaning they prefer the PD20 over the PC20. The endpoint allows comparable results from different devices or protocols. Thus, any suitable nebulizer or dosimeter may be used, so long as the delivery characteristics are known. So how do we interpret this data? The following factors need to be taken into consideration when you interpret the PD20 and PC20, particularly the pretest probability of asthma, including patients' current asthma-like symptoms, the presence or degree of baseline airway obstruction, the quality of the patient's spirometry maneuvers, the pretest questionnaire results, symptoms reported by the patient at the end of the test, the degree of recovery after bronchodilator is administered, the sensitivity and specificity of methylcholine challenge tests in general, and then the repeatability of methylcholine challenge testing. This is a table from the European Respiratory Society that lists the different PD20s, PC20s, and how we interpret them. As you can see here, with a PD20 greater than 400, meaning it took more than 400 to drop the FEV1 by at least 20%, or a PC20 greater than 16, that's considered normal bronchial reactivity. And then there are varying degrees of doses and concentrations, with the one we're concerned about most being the last one here. If the PD20 is less than 6 or the PC20 is less than 0.25, they consider that to be marked airway hyperreactivity. Normally we use the PC20, but lately, based on the European Respiratory Society guidelines, I've been taking into account both the PD20 and the PC20. In my opinion, it's easier to follow the PC20. But as you can see, based on the different values listed, there's different degrees of interpretation when it comes to the airway hyperreactivity. So using the degree of airway responsiveness to answer questions about individual patients assumes that the test is properly performed, that no modifiers that would artificially alter the airway responsiveness were present, and that the patient's prior probability of having current asthma can be reasonably estimated. If the prior probability or pretest probability of asthma is between 30 and 70%, then a PD20 greater than 400 mics or a PC20 greater than 16, it may be stated with a high degree of confidence that the patient does not currently have asthma. On the opposite end of the spectrum, if the PD20 is less than 6 or the PC20 is less than 1, the test provides strong confirmation of the clinical diagnosis of asthma. However, when you get into the gray area, meaning a PD20 between 25 and 400 or a PC20 between 1 and 16, you have to be more cautious about stating whether or not the patient actually has asthma. It has been suggested that when the PD20 or PC20 is low, and the asthma-like symptoms induced by methacholine challenge are similar to those previously reported by the patient, confidence in a diagnosis of asthma increases. So the pretest probability, or the prior probability, is the likelihood that the patient has asthma before methacholine challenge tests are even considered. The post-test probability is the likelihood of asthma considering both the pretest probability and the methacholine challenge test results. And the difference between the two represents the contribution of the methacholine challenge. I like this graph. They provided from the European Respiratory Society. On the x-axis, it lists the pretest probability, and the y-axis, the post-test probability. Each line represents a different PD20. They're using PD in this case. For example, if you take the PD20 of 25 mics, you can see that for any given pretest probability, we'll say 0.3, the post-test probability is significantly higher compared to that of a patient who has a PD20, let's say, of 400. And this gives a good graphical representation of how pretest probability is factored in when obtaining PD20 or PC20 results, and how that all needs to be looked at and assessed together when making a clinical diagnosis of asthma. In people with a PD20 between 25 and 400, or with the PC20s between 1 and 16, and who have no asthma symptoms, which is probably an unusual circumstance because methacholine challenge would not be clinically indicated in that setting, there can be several possibilities. One being that there is a mild intermittent asthma, but the patient is a quote unquote poor perceiver of asthma symptoms. After exercise or inhalation challenges, the patient experiences chest tightness that is perceived but not recognized as abnormal. The patient never exercises or experiences environmental triggers of bronchospasm. The mild broncho hyperreactivity is due to a cause other than asthma, things like post-viral upper respiratory infection, cigarette smoking, or there's a subclinical or asymptomatic asthma that will become clinically apparent in the future. In patients with a diagnosis of asthma, the correlation between the degree of airway responsiveness and clinical severity of asthma is significant, but not strong enough by itself to categorize the severity of asthma in individual patients. Recent exposures causing airway inflammation or residual effects of anti-inflammatory therapy like systemic or topical steroids can easily change the degree of airway responsiveness so that the PD20 or PC20 doesn't actually reflect the quote unquote usual untreated severity of the patient's asthma. It's difficult to interpret the meaning of a low PD20 or PC20 in a patient with baseline airway obstruction. For instance, most patients with smoking-related COPD and mild to moderate baseline airway obstruction have bronchohyperreactivity, but most have no acute or chronic bronchodilator response or symptoms of asthma. This is just a sample methacholine challenge test report form. This is provided by the American Thoracic Society. It's a very simplified form. We use a variation of it here at Robert Packer. But as you can see, it lists the time of first the baseline spirometry and then the timing of each dose, and then the drop in FEV1 with each dose. These are our own policy and procedures for performing bronchoprovocation testing here at Robert Packer Hospital. It lists the different policy, the procedure, and then the purpose. As you can see, the purpose is pretty much what you'd expect to assess the airway responsiveness in patients who have stereotypic symptoms of asthma. Let me see here. The contraindications we use are pretty similar. We have a contraindication of an FEV1 less than 70. If they've had a heart attack or stroke in the last few months, uncontrolled hypertension, pregnancy, things that were all listed in the recommendations by the European Respiratory Society and American Thoracic Society. It lists the same thing regarding safety that I had mentioned earlier and the need for appropriate personnel and equipment to be available during the procedure. Here at Robert Packer, we use a breath actuated nebulizer. Like I said, we use a variation of the 2-minute nebulizer method. And then we use the methacholine in 5 concentrations listed here: the 0.065, the 0.25, the 1, the 4, and the 16. We do a similar pretest questionnaire, and we always assess patients for any medications that may interfere with the accuracy of the test, including their home inhalers and other oral medications that could potentially interfere, but of course, mainly the inhalers are the most important one. And then we have time periods that we tell them that they need to hold their inhaler for prior to testing. Same procedure, we explain to the patient what we're doing, why we're doing, and what they should expect. Always ask them to urinate before the test. They sign the consent form, and then we evaluate them for any contraindications. So like I said, we use the breath actuated nebulizer. We prepare the methacholine. We always assess the patient demographics first, and we perform a baseline spirometry. Here, if the FEV1 is greater than 70% are predicted and greater than 1.5 liters, we continue with methacholine challenge as ordered. But if it's less than 70, we perform spirometry only and document the contraindication for methacholine challenge. Click on the pre-drug tab and select, these are all technical details essentially, but we start with the lowest concentration, the 0.0625 milligrams per milliliter. We put it in the nebulizer, and we essentially administer the test in a manner similar to what I described before. We measure the FEV1 after 90 seconds, after the 20-second nebulization of the breath actuated nebulizer. And then we also record the target FEV1 will be 20% below the value obtained from the control. We always report the highest FEV1 when multiple forced vital capacity maneuvers are used on the same drug concentration. If the FEV1 declines less than 20%, click on Next Set. The protocol will again display with the next concentration in the protocol highlighted. We empty out the nebulizer, add a milliliter of the next increased dose or concentration, and then repeat the following steps. Again, we're all trying to obtain the value here, which is the PC20, or the provocative concentration that causes a drop in FEV1 by 20%. This is our simplified table for the PC20. If it's greater than 16, that's normal bronchial responsiveness. Between 4 and 16, it's borderline. 1 to 4, it's mild. And less than 1, we can consider that marked or moderate to severe. This is an example methacholine challenge of a patient here at Robert Packer. As you can see, we start with baseline spirometry. Interestingly, this patient had an FEV1 FVC that was less than 70 and less than the lower limit of normal. So they actually already had baseline obstruction, but the FEV1 at baseline was 97%. They proceeded with testing. And here's the baseline column that shows the FVC, the FEV1, and the delivered concentration and dose. They started with the first concentration with 0.06, and then the FEV1 dropped by only 7%. They did the next concentration of 0.25. They recorded the next FEV1. And then by the time they got to the third, they noted that the patient's FEV1 dropped by more than 20%. So the test was concluded and the patient received an albuterol treatment. This is a graphical representation that the computer will provide, noting the baseline spirometry here, the FEV1, and then the drop in FEV1 with the first concentration, the second concentration, and then after the third is where the patient developed a drop greater than 20%. And then this is the rapid reversal after administration of albuterol. The PC20 was listed as a 0.78 and the PD20 of 3.91. So based on PC20, we can say that this patient has moderate to severe hyperresponsiveness. These are the different spirometric flow volume curves shown throughout the testing. As you can see, there is concaving of the expiratory limb, indicative of expiratory airflow limitation. So that was a lot. I'm just going to summarize the first portion here. If you're going to take away anything from this part, just know that asthma is a clinical diagnosis. There is no true gold standard testing, but you can use objective data, PFTs, bronchoprovocation testing, to help support the diagnosis in the appropriate clinical context. The most common indication is a strong clinical suspicion for asthma, but normal spirometry. It's important to review any potential contraindications prior to testing. The two most common protocols are the 5-breath dosimeter and a 2-minute tidal breathing. The goal of the test is to determine both a PD20 or a PC20, and it's important to factor in the pretest probability of asthma when interpreting the test results. Depending on the clinical context, pretest probability, patients with a PD20 less than 6 or a PC20 less than 1 are generally highly likely to have asthma. And patients with a PD20 greater than 400 or PC20 greater than 16 are generally highly unlikely to have asthma. Are there any questions so far before I go on to the next portion of the presentation?
Mansur, I do not see any in the chat box right now, but if anybody has a question, they can put it in there or ask it at the end.
Okay, sounds good. I will go on to the next portion. We're going to talk about exhaled nitric oxide. So what is it? At its base form, it's an atmospheric pollutant present in vehicle exhaust emissions and cigarette smoke. But it's also a biological mediator in animals and humans. It can result in several different actions, including vasodilation, bronchodilation. It can act as a neurotransmitter. It can also act as an inflammatory mediator. It's a highly reactive molecule, free radical with oxidant properties, meaning it can be bactericidal and has cytotoxic effects. It's actually produced by the human lung, and it's present in the exhaled breath. It's been implicated in the pathophysiology of lung diseases, including asthma. And the measurement of exhaled nitric oxide has been standardized for clinical use. There are numerous studies that have provided evidence regarding the applications of nitric oxide measurements in clinical practice. In general, asthmatics tend to have higher levels of nitric oxide in their exhaled breath. It does play a complex pathophysiological role in the human lung. It acts as a pro-inflammatory mediator and predisposes to the development of airway hyperresponsiveness. But under physiologic conditions, it acts as a weak mediator of smooth muscle relaxation and can actually protect against airway hyperresponsiveness. It can be regarded as an indirect marker for upregulation of airway inflammation. So the guidelines actually recommend the use of the term FeNO, or the fractional exhaled nitric oxide concentration, to describe the level of nitric oxide in the exhaled breath. From here on out, I'll just refer to it as FeNO. The FeNO itself is expressed in parts per billion, which is equivalent to nanoliters per liter. So how do we measure the FeNO? Well, back in the day, they used something called chemiluminescence analysis. It allows for the determination of nitric oxide concentration in gas phase by reaction of the nitric oxide in the sample with ozone to produce nitrogen dioxide in an excited state. This nitrogen dioxide moves to a relaxed state. Light is emitted in a stoichiometric relationship with the amount of nitric oxide present in the gas sample. This technology was used in the first FDA-approved devices. Later on, they came up with other technologies, including handheld devices using electrochemical methods. And this is a sample photo of a machine that uses chemiluminescence analysis. As you can tell, it's quite bulky. And these are examples of some of the more modern available handheld devices that you can use to measure FeNO. This is the NEOX Vero device, and this is the bed font nitric oxide breath analyzer. As you can tell, they kind of has a standard appearance to them with a mouthpiece and a small screen to obtain data. So exhaled nitric oxide can be measured online while the subject exhales directly into the analyzer, or offline, in which they'd have to collect the exhaled air in a nitric oxide impervious container and then later measured. With online measurements, the patient exhales at a constant flow directly into the analyzer, and the mean FeNO value over a 3-second plateau is recorded. In order to achieve an appropriate plateau, the duration of exhalation must be sufficient, at least 4 seconds for children less than 12, and more than 6 seconds for children greater than 12 and adults. They have to maintain expiratory flow rate of at least 0.05 liters per second throughout the exhalation. With offline measurements, they use an apparatus to collect the exhaled air without loss of nitric oxide. Then they must deplete the inspiratory air of nitric oxide prior to inhalation. They have to maintain an expiratory flow rate of 0.35 liters per second throughout the exhalation. They have to exclude the nasal nitric oxide. This is important as these levels are high relative to the lower respiratory tract levels. A nose clip is generally not used, as this may allow nasal nitric oxide to accumulate and leak into the posterior pharynx. After inserting the mouthpiece, the patient inhales through the mouth to total lung capacity and immediately exhales completely. Having maintained the patient a positive mouthpiece pressure at about 10 centimeters of water during exhalation helps to close the velopharyngeal opening and minimize nasal nitric oxide leakage. Of note, ambient nitric oxide levels should be recorded at the time of testing, as this can influence test results. I mentioned earlier that expiratory flow rates are important. The exhaled nitric oxide levels are dependent on the expiratory flow rate. And like I said, with online measurements, you have to maintain a constant exhalation rate of 0.05 liters per second and 0.35 liters per second with offline measurements. How do we achieve a constant flow rate? What methods do we have? Well, there's a visual display of the target flow rate while the patient exhales against a fixed resistance, the use of a dynamic resistor, and then there's operator-controlled flow rates as well. In any case, the flow rate should be recorded with the test results. So why do we measure FeNO? It can be used to assist in assessing the etiology of respiratory symptoms that are not specific. It can help identify specifically the eosinophilic asthma phenotype. It can assess potential response or failure to anti-inflammatory agents, particularly inhaled corticosteroids. Sometimes physicians will use it to obtain a baseline FeNO during clinical stability, and then use that for subsequent monitoring of chronic persistent asthma. It can also be used to guide changes in the doses of your anti-inflammatory medications, whether you want to step down, step up, or even discontinue your inhaled corticosteroid. It can also be used to assist in the evaluation of a patient adherence to inhaled corticosteroids. And it can be used to assess whether airway inflammation is contributing to poor asthma control, particularly in the presence of other contributors, patients who may have rhinosinusitis, anxiety, GERD, obesity, other things like that. What about when it comes to diagnosing asthma? Like I said earlier, asthma is a clinical diagnosis. There's no single diagnostic test for the disease. The background pathology of asthma is often, but not always, due to eosinophilic airway inflammation, but the two are not synonymous. This is important when you interpret your FeNO measurements. For example, in cases of asthma not due to airway eosinophilia, FeNO may indeed be low. The American Thoracic Society does provide recommendations for the use of FeNO. They recommend that the use of FeNO in the diagnosis of eosinophilic airway inflammation with a strong recommendation and a moderate quality of evidence. They recommend the use of FeNO in determining the likelihood of steroid responsiveness in individuals with chronic respiratory symptoms that are possibly due to airway inflammation. And they suggest that FeNO may be used to support the diagnosis of asthma in situations in which objective evidence is needed. That one has a weak recommendation, but a moderate quality of evidence. What is normal FeNO? Well, it's unlikely that the reference values used derived from a normal population will be as helpful as specific cut points in patients with airway disease or respiratory symptoms, because there may be significant overlap between healthy patients, normal patients, and those with stable asthma. Factors affecting the population FeNO levels include gender, age, sex, atopy, weight, height, current smoking, diet. And this is a good table showing you what I mean here. FeNO levels tend to range with certain cutoff points in normal patients and in patients who have stable asthma. But as you can see, there's some overlap here. There's a gray zone in which the FeNO level may not be able to specifically, well, it's not specific, and you may see in patients who are either normal or with stable asthma. The American Thoracic Society also provides recommendations for cutoff points for the FeNO. They recommend that a low FeNO, meaning less than 25 parts per billion in adults, less than 20 for children, be used to indicate that eosinophilic inflammation and responsiveness to corticosteroids are less likely. But with a FeNO greater than 50 in adults, it can be used to indicate that eosinophilic inflammation and in symptomatic patients, responsiveness to steroids are likely. However, they note that with gray areas, meaning a FeNO value between 25 and 50 in adults, should be interpreted cautiously with reference to the clinical context. As you can see, the reference ranges are different for children. I like these tables. They're from the American Thoracic Society guidelines. They tell you how you would use a low FeNO level in both the diagnosis and monitoring of patients suspected of having eosinophilic airway inflammation. So if it's less than 25 and you have a symptomatic patient, that means they're unlikely to benefit from a trial of inhaled steroids, and you should consider other possible etiologies for the patient's symptoms, things like non-eosinophilic asthma, rhinosinusitis, COPD, bronchiectasis, and then other non-pulmonary conditions like acid reflux, anxiety, cardiac symptoms, and things that may be confounding this, like smoking or obesity. When it comes to monitoring patients who are symptomatic with an established diagnosis of asthma and of low FeNO, you could consider non-eosinophilic asthma and other alternatives that may be contributing to the diagnosis, like vocal cord dysfunction, like I said, anxiety, bronchiectasis, cardiac disease. On the opposite end, in patients who have high FeNO, meaning greater than 50 parts per billion, if you have a symptomatic patient presenting for the first time, the possible etiologies based on this could include the typical atopic asthma, but you can't also rule out things like eosinophilic bronchitis, COPD with a mixed inflammatory phenotype, and it can also be used to monitor patients who are symptomatic and have an established diagnosis of asthma. Patients who are symptomatic and have a high FeNO with an established diagnosis of asthma, these possible etiologies could include a high persistent allergen exposure, problems with their inhaled corticosteroids like poor adherence, poor inhaler technique, proximal drug deposition. You always have to assess things like that. And this is just a table kind of summarizing what I just said. It divides the groups based on FeNO less than 25, between 25 and 50, and then greater than 50, and how this can be used specifically for aiding in the diagnosis and for monitoring in patients who already have a diagnosis of asthma. So in summary, Advances in technology and standardization have made FeNO measurements very simple, permitting their use as a biomarker in the assessment of inflammatory airway diseases. It is widely acknowledged that asthma is a heterogeneous disease with a variety of underlying pathophysiologic abnormalities, and it does play a role in identifying these different phenotypes. Evidence-based cut points are shown to have diagnostic significance and appear to be more relevant than reference values derived from large population studies. FeNO values of themselves do not justify diagnosis or change in treatment. Again, the theme of this presentation is that these values need to be interpreted in relation to the clinical context. FeNO values may be particularly useful in understanding patients with asthma in whom more than one factor is contributing to their respiratory symptoms, like anxiety, obesity, and for whom clinical decision-making is difficult. Okay, I know that was a lot. I appreciate everyone listening. I'll take any questions that anyone may have right now.
Does
There are-
anyone have,
Yeah,
do we have any
there's
questions?
none in the chat box, but if anybody has a question for him.
I know that was a pretty dense topic and I went through it kind of fast, but this is going to be recorded and I'm sure the slides will be available to you guys. Yeah.
Well, thank you very much. We have had requests in the past to go over pulmonary function tests. So that's why I asked both you and Raj to do that. And we appreciate that. We appreciate you guys taking the time to do that.
Thank you for having us. We really appreciate it. If anyone does have any questions later, my extension, my email, and my cell phone are listed there. Please feel free to contact either me or Dr. Raj, and we can help you guys out with anything in the future.
Okay, thank you so much.
Thank you very much. Great. Appreciate the information.
Thank you, guys.